My name is Mike Smith. I'm the Chief of GI here at West and Luke's, and Dr. Seward is fulfilling the greatest patriotic obligation today, which is serving jury duty. So I have the opportunity and the pleasure to introduce our Grand Round speaker in his place. He sends his regrets. It is my great pleasure to introduce today's Grand Round speaker, Dr. Eileen O'Reilly. Dr. O'Reilly is the Associate Director of the David M. Rubenstein Center for Pancreatic Cancer at Memorial Sloan Kettering, a professor of medicine at Weill, Cornell Medical College. She completed her undergraduate and medical training at Dublin, in Trinity College and Dublin University, St. James's Hospital, St. Vincent's Hospital. And in 1995, she crossed the pond and started a research fellowship at Sloan Kettering, where she has practiced ever since. Dr. O'Reilly is a prolific clinical and translational researcher, evidenced by her remarkable number of publications, her grants, and her positions of leadership both at Sloan Kettering and in international medical societies. But it's very important to note, however, that she has a clear passion for mentorship and teaching. And among her list of mentees are at least 10 of our own internal medicine residents. And we are very grateful to her for sharing her knowledge and passion for understanding gastrointestinal malignancies with members of our own team. Dr. O'Reilly has won several faculty teaching awards, including the Paul Sherlock House Staff Teaching Award for 2014-2015. We are very excited that she has joined us today to help us better understand the role that molecularly targeted therapies can play in the management of pancreatic adenocarcinoma. And I ask you to please join me in welcoming Dr. Eileen O'Reilly.
Good morning. Thank you so much. It's a real honor and privilege to be here. And as mentioned, I've had the opportunity to work with a number of terrific residents over the years, and delighted that is been a very active endeavor. And we've several of your group who are working with us at the moment. So thank you for that. It's really appreciated, and I always love meeting people from here. So the talk today is pancreas cancer, not so much about the traditional approach to this disease, but more where the field is and where we're going. I just want to acknowledge my disclosures. It always looks like an active list, but there are two of us, so half is myself and half my husband, as we're both in an academic field. So the topics for discussion, a little bit about the background of where we are with this disease. I'm going to talk a fair bit about genetics of pancreas cancer and what that means in terms of potential therapeutic applications, and then review for the latter part some of the novel therapeutics that are in mid to late stage development and have the potential for changing outcomes in this disease. So just to set the scene here, these are some of the, I guess, stark statistics of this disease. Many of you may be aware that this cancer continues to be on the rise, and it's projected by 2020 that it'll be second only to non-small cell lung cancer with regard to leading causes of cancer-related malignancy. And that's kind of fairly frightening when you think about it, because for any other solid tumor, be it breast, prostate, colon cancer, etc., even non-small cell lung cancer, they've all stabilized in terms of mortality and even started to decline. And that's in clear contradistinction to pancreas cancer. And, you know, the big question is why, and that's not fully understood by any means, but there are several putative explanations. Where population is getting older, that's certainly a factor, given that the median age for diagnosis here is 71. But a fair bit of the increased risk may be lifestyle considerations in terms of diet, nutrition, in terms of lack of exercise. But there are clearly multiple other factors that have not been well identified that account for this. And I think this is all coming to the fore in the last, I would say, 5 to 10 years, that people sort of realize that there's, you know, a public health crisis here at hand with regard to what's happening with pancreas cancer. And I think that's resulted, fortunately, in a resurgence of interest in this disease, and indeed increased opportunities for funding, which is always very welcome. So a big question is why is this such a difficult cancer to treat? And again, no clear, I would say, satisfactory explanations, but some certainly putative explanations. And people are aware that pancreas cancer is typified by epithelial cells, but they can be relatively few epithelial cells in this dense stroma, which is considered somewhat hostile. It's relatively hypovascular, it's hypoxic, and there's profound immune suppression in the environment of pancreas cancer cells. So there are some immune effector cells present, but they're not doing their job, and they're more on the suppressive side with macrophages, etc. And the T cells that are present are not activated. One of my melanoma colleagues shows a nice picture of what melanoma looks like with an epithelial malignant cell and T cells kind of stuck on the malignant melanoma cell. And you show a similar picture with pancreas epithelial cell, and you'll see almost a mile away is the inactive effector cell. Maybe it's not as simplistic as that, but certainly a picture tells a lot of stories in this regard. One of the challenges of this disease, and this is again distinct to almost every other solid tumor malignancy, is arguably we don't have validated biomarkers for routine clinical decision making, although I think that's changing, and hopefully will convince you that there are some that are clearly proximate on the horizon. And even for our best therapies, there's inherent resistance in terms of treatment advantage. So all of these add up to the many challenges of pancreas cancer. So this is the lay of the landscape at the current time, and you'll see that it's dominated by cytotoxic therapies. And perhaps the biggest impact recently has come from the advent of multi-agent cytotoxic therapies with gemcitabine, nab-paclitaxel, and FOLFIRINOX. They've been present now since the early 2013, 2010, respectively. The two drugs that are highlighted in red are targeted agents. Erlotinib was FDA approved in 2007. It wasn't approved in the context of its targeted opportunity. There was a very modest incremental advantage for adding erlotinib to gemcitabine. But we now know that there is a subset of patients who actually benefit from this, and that's the small subgroup who've KRAS wild-type tumors. So we'll come back to that. And then equally, there's a small subgroup of patients that benefit to immune-based therapies, and they're the group of people who have mismatch repair deficient or microsatellite unstable pancreas cancer, which is conservatively 1%, but maybe 2% of this disease. Nonetheless, it's certainly a subgroup we try to identify because there are other implications of that, and we'll circle back to that. So moving to the topic of genetics and genomics for this disease, I suspect many of you are familiar with the MSK Impact platform, but this is an integrated molecular profiling platform that was designed about 8 years ago now, and this has been sort of very widely embraced, and there have been a number of significant publications from this. But essentially, it's a clinical trial that allows us to perform next generation sequencing, initially just somatic profiling, but in the last few years, germline profiling for people with advanced malignancies. And this is a schematic that just captures how it's done. This process from tissue in hand to reportable information in the medical record takes about 3 weeks, for adding an extra couple of weeks when tissue has to be retrieved. So this information is externally available in the CBio portal, and I suspect many of you have had the opportunity to review this. Some amount of the molecular information is clinically annotated, but not all of it. And more recently, germline information is being incorporated there. So this has proved, I think, a very valuable tool and resource in terms of understanding what's going on at a molecular and genetic level in many malignancies. So I'm going to show you some of the data. So this is how it's done. Patients who elect to undergo molecular profiling are consented under this clinical trial. This has now become FDA approved and ultimately is a billable test where there's potential actionability for a given solid tumor. For every patient, we draw normal or germline DNA. Initially, this was just for subtraction, for better calling of what's in the tumor directly, but now that germline, as mentioned, has proved extremely important. And this is New York State and CLIA approved, hence it's clinically interpretable and actionable information. So this was our first pass in terms of looking at this in pancreas cancer. So a big question was, can you actually do this in pancreas cancer with the limitations of tissue availability, specifically for patients with locally advanced disease who are often working from a small finely needle aspirate cytology or microcore, or indeed for metastatic patients where traditionally, again, documentation of advanced disease has been made by FNAs. That's changing, and there's now a big interest in doing prospective biopsies and additional sequential biopsies, which was considered sort of heresy a number of years ago. But I think there's a lot of learnings that have come from this, not necessarily clinically actionable at the moment. So this just shows you the samples as we did it. This was when we started this program in pancreas cancer. It was really, there was a lot of kind of pent up demand. So it was not just new patients who came in the door, but it was patients who had been looking after for a number of years who were able to undergo profiling. And for some, it came from archival specimens. For some, it came from previously acquired tissue. And you can see the distribution of resected, locally advanced, and metastatic specimens, and the site of metastasis for those in whom the tissue was taken from a metastatic site. So this is the brief summary. It took about almost 5 weeks to have information from most patients, but for the most part, the big delay was getting tissue where it wasn't present at Memorial, and where we did, 3 weeks was the time. Nonetheless, this doesn't give us real-time information to be able to utilize upfront, although I think in certain circumstances that is doable now, but mostly it's providing information for second line and perhaps clinical trial application going forward. So this is an oncoplot, and for those that may not have seen one of these before, each vertical line going from your left to your right represents an individual patient. It indicates where the sample type comes from, and then the somatic or tumor-based profiling. And just a couple of things to point out. Pancreas cancer is characterized by a predominance of driver oncogenes that are not targetable at this time, although there's a lot of effort in terms of KRAS, and the NCI have a major focus in revisiting KRAS, and there's some hints now in some exons of KRAS that we may be able to have opportunity, and this is being in particular emphasized in the management of non-small cell lung cancer. But KRAS, P53, SMAD4 and CDKN2, they're the key 4 driver oncogenes. And there's a fair bit of data suggesting the more oncogenes that an individual has mutated in their tumor, the more aggressive the phenotype of the cancer, and vice versa. This is not absolute, of course, and we don't at this time have any clear information correlating treatment outcomes matching to this type of somatic genomics. The importance in terms of actionability is a little bit lower down. On the left side, you'll see there's a smattering of lower frequency oncogenic events, many of which do have treatment implication for patients, and I'll show you some of the clinical data related to that in a little bit. So we mentioned erlotinib and KRAS wild type. It's a small subset. It's probably about 5 or 6% of people with pancreas cancer. But one of the important findings here is for that group of patients, they're particularly enriched for treatment implications in terms of BRAF mutations. You'll see there's a patient who had an NTRK fusion, a patient who had a ROS fusion, and both of those, there are drugs that are available now that have had significant impact. These are, again, very low frequency events, but for the individual, arguably this makes a significant difference in outcome. So a secondary goal of this initial look was to see what was our success in terms of genomic finding and applied treatment. And again, this was not the primary purpose at all. And in pancreas cancer, this can be particularly challenging. As we all know, these patients, their disease can be stable, and suddenly kind of fall off that precipice. And that's particularly so in later stages of disease where you have a genomic finding and you're trying to either identify a clinical trial that's open and fits, or get access to an off-label drug. So I wouldn't want you to think that this isn't an opportunity here, but just this was the first look at this. And there were a number of important findings. I think the BRCA subgroup, and again, I'll go through this in a little bit of detail, it clearly is the biggest group that there's treatment implications. For this particular analysis, the BRCA-directed therapy came from the Germline findings and wasn't directed off the somatic results, but that could equally be where the information came from. And a small subgroup of patients with Lynch syndrome, if you go back, the big peaks on the top part of the picture there are the hypermutated tumors and the group that are potentially susceptible to immune-based therapies. So what can we sum up with regard to this experience? It's certainly very doable, and that question of feasibility is gone away. And our colleagues in IR and GI have really kind of helped move the field forward here. And now it's fairly routine to try and get a decent multiple passes in terms of FNA, generate a cell block, and even sometimes some small cores which facilitates this process. So I think a lot more to come, and our current project is sort of updating this with regard to treatment implications. So moving to the genetic aspects of pancreas cancer. So the second part of this clinical trial, and this again is a pan-institutional effort, was looking at germline testing. When they started, it was a panel of about 76 cancer predisposition genes that's slightly been expanded, although in truth, about a third of these are relevant specifically to pancreas cancer. And it's sort of a neat way that this is done. The way we used to do it is we would identify somebody in the clinic based on family history or heritage and refer them to genetics. The problem, our genetics colleagues are so busy, and the disease trajectory is an active one that oftentimes they wouldn't get there in a time frame that was meaningful for them and their family. So we clearly had to revisit this model, and what we do now is we do counseling in the clinic, because New York State requires germline pre-test counseling. By verbal discussion and by use of an educational video tool. It's a 6-minute video that patients and families watch, and almost everybody with pancreas cancer has opted to consent because people recognize opportunities are finite in this disease, and I think there's a huge wish, if it is not for the individual themselves, it's how we can help the next person and how we can help their family. So I would say there's been extraordinary interest in this, and I think now we've germline consented, it's almost 1,000 patients, and I can think of the number of people who've declined as a single-digit effort, so it just speaks to the interest. If patients turn out to have a positive mutation, we as their physicians will communicate that, and then our colleagues in genetics will arrange either an in-person or telephone-based consultation, and this really has enormously increased the efficiency of this, as it needs to be kind of mainstream and practical in its application. So in pancreas cancer, we really don't have good guidelines as to who we should recommend germline testing. Most of the guidelines are adapted from hereditary breast and ovary cancer syndrome and from some of the single gene mutation findings. And why should one do it? Well, I've alluded a little bit. I think the biggest potential application is for the individual's family right now in terms of identifying people who are at risk, not just of pancreas cancer, but of other related malignancies. So in terms of screening and theoretically prevention opportunities. But increasingly, the argument is for the individual for homologous repair deficiency gene identification in terms of treatment application, and more recently, the era of immune therapy for the small subset in whom this is relevant. So this was a pan-cancer analysis of germline findings that was reported last year by Diana Mandlikar. She's been one of our main collaborators in this area. And just looking at the first 1,000 plus patients who underwent somatic testing and had secondary germline analysis. And in this first pass, the point to note is the frequency of germline findings is quite high across multiple cancers, but in particular is enriched in pancreas and prostate cancer. So in this first pass, about 15% had a germline finding, and I've listed some of those findings there. And we elected then to look at this in significantly more detail to understand what the pattern of findings were, what the family and personal history of those patients were, and also to get a sense of, is there a difference in outcome? Do these patients who have germline mutations, do they have a better outcome, dependent or independent of therapy? And this was a complex project, and it had multiple collaborators in genetics and molecular oncology, along with our clinical colleagues. And there were two groups, a group of patients in whom we had consent to look directly at the germline, and then an earlier group of patients before this was happening routinely, where we didn't have direct consent and hence had to do an anonymized analysis, which was very complex, and we couldn't look at any clinical outcomes, because if we identified a particular individual, the question is how we were going to communicate that. So at the end, we weren't able to look at outcomes in that part, but nonetheless, it proved to be, I think, a very fruitful project. So this is the broad summary. This is a group of 600 patients. So firstly, was there a difference in age for those who had germline mutations versus not? And as you might expect, there was. It wasn't a huge difference compared to some other diseases. It was 60 years versus 66 years. And this is a little bit younger in general, which probably reflects the population of patients that we see in terms of referral bias to Memorial. As you might imagine, in New York City, enriched for people with Eastern European Ashkenazi heritage. And in that group in particular, there was a high possibility of identifying a germline finding. But the additional point to note is equally important in people who didn't have any Ashkenazi heritage. There was still a significant chance of identifying a finding. And what about the age question? Present in about a third of patients under 50, but also present in a group of patients who are older than the average. And I guess the key point that we learned from this, which we sort of knew anyway, but we have to discard those biases in terms of thinking about it. And one striking example from last year is the identification of an 88-year-old who came to the clinic with a locally advanced pancreas cancer. And she turned out to have Lynch syndrome and was the first family member to be identified with Lynch. And it kind of breaks all the rules in terms of how you would think about it. But for that individual and for that family, obviously extremely important in terms of the implications. So this is the pattern of genetic findings that we see. Predominated, as you might expect, by BRCA1 and 2 in particular, but a number of much lower frequency other genes. And the good news from the Therapeutic actionability is many of these are genes that are involved in homologous repair and DNA damage strategies, for which we have drugs both standardly available and experimentally for application. And you'll see there that even some patients had a couple of germline mutations, and we also identified some genes that have not previously been, they haven't been previously characterized as being definitively associated with pancreas cancer, but are fairly high suspicion, and we'll certainly need greater numbers to be certain about this, is that they likely are for those individuals and families. So going back to the question of outcome, is there a difference in outcome if you carry a germline genetic mutation? We were probably not powered to answer this question, but we certainly get a hint that there might be. The group of patients who had a germline finding had a median survival of about 50 months. Those that did not was about 34 months. This did not meet a statistical significance, but I suspect it will with time. And you'll notice these outcomes are kind of interesting, but it's just to make the point that it's an unselected population. These were patients who walked in the door, and essentially every patient that elected to consent, which was nearly every patient we saw. So in one regard it's selected, but in another the numbers take away a little bit from that bias. So where are we with this at the current time? So we look to see who met guideline testing, again, acknowledging the point that the guidelines are applied from other diseases. And it was clear that about 40% of people did not. So we're actively working with ASCO and NCCN, and I have the privilege of being members of these panels in terms of guidelines for pancreas cancer to make this part of standard of care for patients who walk in the door on a routine basis. So these are the conclusions from this project. I think significant implications for individuals, for families. Clearly, we've under-recognized these observations, and again, you can argue the more genes you look for, the more you're going to find. But nonetheless, in terms of clinically important genetic findings, it's significant. 20% was the overall number. The part that's probably important is probably about 12%, but that's 1 in 8 people that we meet. And about 5 to 10% of these patients have therapeutic actionability. And if you add that to the somatic findings, that's probably 20% of people with pancreas cancer. So it becomes a number that's tangible and I think meaningful. So with that, I'm going to speak to what's happening from the therapeutic perspective, and I'll circle back to the genetic part in a minute. So a lot happening in the field, and I'll just highlight some of those that are active and where we have some preliminary results and pending some phase 3 results. These are some of the key areas, looking at stromal degradation, looking at homologous repair targeting, stem cells, immune therapy, of course, and several other applied approaches. So I know you can't read this, but I show it for one reason, and it's to kind of highlight, I think, the excitement in terms of what's happening with the array of therapeutic early phase opportunities that are in development in pancreas cancer, targeting the microenvironment, the cancer cell directly, the stroma, immune approaches. So the good news is that there's a lot happening in this space. So looking at the microenvironment, and just to go back to this, we talked about this at the beginning, the fact that it's a very kind of privileged entity in terms of dearth of epithelial cells, a lot of immune suppressive cells. And you'll be aware of an enzyme called PEGPH20, which has been known for years, injected into joints as a hyaluronidase degradation enzyme that was modulated, made pegylated for sustained clinical use. And that's been shown to alter this microenvironment. In one sense, it sort of directly punches holes, the simplistic idea being that facilitates drug delivery. One of the counterpoints is that might facilitate epithelial malignant cells exit, which wouldn't be such a good thing. And there's some dichotomous information, I would say, related to that observation. But nonetheless, this has spurred a series of clinical trials, and this is a mid-phase study that was recently reported. This is a trial conducted in patients with metastatic pancreatic adenocarcinoma untreated, where they got allocated to standard therapy with gemcitabine, nab-paclitaxel, or standard therapy plus this pegylated enzyme, which is given by intravenous injection. And this was looked at in all comers who were enrolled in the trial, and a subset of patients who had elevated levels of hyaluronan, a biomarker that was evaluated by immunohistochemical staining. Those that had high levels looked to be a subgroup that might benefit based on the earlier phase studies. And these were the observations, looking at the principal endpoint of progression-free survival, so how long the cancer was controlled. If you had an elevated level of hyaluronan, that's on the panel on your right. The blue line is that subgroup of patients. The yellow line in that right figure is the group of patients who received standard therapy. So certainly a hint here that there might be something favorable happening. Nonetheless, this was not a home run, I would say, in that a secondary endpoint was looking at survival in the overall cohort and in the subgroup of patients that were biomarker selected. The study was not powered, in truth, to answer the survival question, and numerically there was a trend, but you'll see the curves overlap. So we sort of have to await the ongoing phase 3. But one of the other observations that came about fairly early in terms of development of this, and this trial was put on hold by the Data and Safety Monitoring Board and the FDA because of an excess of thromboembolic events in the subgroup of patients who received the pegylated enzyme. And this caused a risk mitigation strategy to be included, which was ultimately successful, using therapeutic dosing of low molecular weight heparin. And you'll see for both subgroups, ultimately in the later phase of the study, if you look at the bottom line there, the excess risk was reduced to close to baseline. And venous embolic events are a concern, but what was also observed initially was there were several arterial events in terms of TIA and CDAs, which obviously heighten the concern with regard to the implications of that. But at least it looks like that's been addressed and safely addressed. So what's happening? The update on this is that an ongoing phase 3 in a subgroup of patients with elevated hyaluronan is now underway, and several of the big cancer centers in the city are participating in this. This is about 2/3 accrued, and we'll look forward to having results. So there's a counterpoint, though. There was some data presented at one of our oncology meetings earlier this year from the Southwest Oncology Cooperative Group, which looked at a different cytotoxic backbone of FOLFIRINOX, which is an alternative standard frontline treatment. This study was conducted in an unselected population, so retrospectively biomarker analysis has been done, but all patients with good performance status were enrolled. And there were 2 groups randomized, those who received FOLFIRINOX plus the pegylated enzyme and those that were on the standard arm. And the results were striking and shocking, I would say. The striking part is that the standard arm did well, and actually maybe even compared to the original trials did a little bit better than expected. But the shocking part was that the group who received the pegylated enzyme had a much worse outcome and higher toxicity and shorter period of time on treatment. And that is completely unclear why, as to whether it's the cytotoxic backbone or whether it was the unselected patient population. But this has caused, understandably, a little bit of pause in terms of what it means overall for where this drug is going. And I think right now we really have to wait for the maturation of the other phase 3, but it's clearly not going to move forward with FOLFIRINOX. So what else is happening? A little bit about other tyrosine kinase inhibitors. Ibrutinib, people probably know well from the CLL and hematologic world, where it's been a standard drug now for a number of years. It has very interesting effects on the microenvironment and B and T cells. And there's a large late phase pancreas cancer trial that's been completed based on interesting preclinical data for which we should have results very shortly. And it's possible that there may be an altered standard of care based on this. So more to come on that. So moving to the genetic opportunities in pancreas cancer from the treatment perspective. And just a reminder here that there are a lot of genes that are associated with increased risk. These are the ones that are most well known, and we've talked about this a bit already with the BRCA subgroup, HNPCC, and a smattering again of other lower frequency genomic events. So specifically talking about germline BRCA, if you take an unselected population of 100 people with pancreas cancer who walk in the door, about 5 to 7% will have a germline BRCA mutation, more likely to be present in those with Eastern European heritage, people with familial pancreas cancer where there's 2 or 3 first-degree relatives with this disease. And a reminder too about the concept of synthetic lethality. So BRCA deficient or BRCA mutant cells have an ineffective ability to repair DNA damage. And that's the therapeutic advantage that using platinum drugs or experimentally PARP inhibitors provide. Normal cells, the predominant survival pathway is by homologous repair, but that's significantly infected in the mutant cells compared to normal cells. And we know in pancreas cancer, we have a subgroup of patients, and depending on how narrowly or broadly you define that, that's 5 to 8% to 25% if you include all the somatic genes. There's opportunities here. So this was a study that we looked at. We looked at the addition of a PARP inhibitor, veliparib, to cisplatin-based therapy in a group of patients with untreated pancreas cancer. There were 2 cohorts, those mutation and those that did not. And you'll see that there was very striking difference in the outcomes. Those who had a germline mutation had a very high response rate. That's the blue vertical lines. Those who did not had no objective responses to this treatment. And similarly, when we looked at the swimmer's plot, so the longitudinal period of time on treatment, it was substantially higher for the BRCA mutated patients. And this was an example of one of the patients who was in the trial. This was a lovely lady in her early 40s. She had just been identified to have a germline mutation because her sister had been diagnosed with ovary cancer. And several months later, she started to feel unwell and was diagnosed with metastatic pancreas cancer, quite a volume of liver disease, and had impending duodenal obstruction and biliary obstruction at presentation. She went on to have a near complete response maintained for a little over 3 years. It is anecdotal, admittedly, but I would say it's not atypical for this subgroup of patients, and that's an observation that we've, I would say, somewhat reproducibly seen. So in this initial analysis, we looked at survival outcomes, and again, this was non-randomized, so there's a lot of caveats on a small study, but we saw survival for what we would expect from the literature for patients who didn't have a germline mutations, and those who did, who got platinum and PARP inhibitor-based therapy, had about a doubling in outcomes. So that's pretty significant, and particularly if you put it in the context of the historical data, where there's been a lot of evaluation of platinum-based therapy in unselected groups of people with pancreas cancer. And you'll see the median survival was in the 6 to 7 month range, in contrast to approximately 2 years for the group who have a germline mutation. And this is metastatic pancreas cancer. So that led us, all the data that we've shown you, to develop this prospective randomized trial, which is almost completed recruitment. This is an international collaboration with the NCI, with colleagues in Israel and several centers around the country, looking at the addition of PARP inhibitor upfront to platinum-based therapy to see if that increases depth and duration of response along with survival. And there's a whole series of correlative studies built in around the science of this. So the other question that's being asked is looking at maintenance PARP inhibition, and this is applied from the ovary and breast cancer world, where PARP inhibitors are now standard of care for groups of patients with germline and indeed subsets with non-germline mutations. And this study is a registration trial in pancreas cancer that's probably around 3/4 of the way accrued. This, again, is an international study, and the high probability is that PARP inhibitors will become a standard option, either as a result of this study or hoping that the FDA in the interim, in the wisdom, might elect to make a disease-agnostic adjudication of PARP inhibitors and say for patients who have germline mutations, irrespective of the underlying disease, that this class of drugs have therapeutic advantage. And there's a large amount of data now to support that observation. So just in the interest of time, I'll just spend maybe 5 minutes talking about immune therapies in pancreas cancer, obviously an extremely topical subject in every malignancy. It's been, I would say, a hard challenge in this disease, but again, there's a lot happening. This is borrowed from one of my colleagues at Penn, who provided a nice schematic of what's happening in the field with regard to treatment opportunities in the immune setting. So firstly, are there any data to say that immune therapy works? Well, there's small amounts of data. This was a study from a number of years ago now looking at anti-CTLA-4 antibody ipilimumab, and there was, in this trial, there was no initial objective responders, but one patient initially had disease progression, and then beyond the time point of the trial, their disease started to regress, and clinically started to get better, and CA19-9 declined. So that was a real delayed response, but wasn't actually included as part of the study because the patient had progressed initially. We don't know whether that patient was mismatch repair deficient, but it's certainly possible. And there have been some other single agent data looking at PD-1 and PD-L1 inhibitors. This is my colleague from Memorial, Neil Siegel, who reported a large pan-tumor cohorts of PD-L1 treatments at ASCO. We're still waiting the final publication on this. This was a 400-patient study, but there was a small subset of patients with pancreas cancer. There were a couple of objective responses that were sustained. But nonetheless, if we look at checkpoint inhibitor therapy in this disease, the outcomes are clearly disappointing. This is looking at response rates from the most responsive to the least responsive disease. And as one might predict, pancreas cancer is on the extreme right. So clearly, single agent checkpoint inhibitor therapy on its own aren't cutting it in this disease. And that's resulted in lots of opportunities. So combining checkpoint and checkpoint, interesting, I'll show you some data. And then a current strategy is building on standard therapy. So building on chemotherapy, building on radiation-based approaches. So this is a study that we recently completed and are now writing up, looking at 2 checkpoint inhibitors, PD-L1 and an anti-CTLA-4. Unfortunately, we didn't see a signal in a second-line setting. And in fact, compared to historical reference for what chemotherapy does in this setting, this was inferior, I would say. So again, it's clear that checkpoints on their own or in combination aren't sufficient. But this is where the money is right now. It's building on cytotoxic therapy. This is a Parker consortium study. So from the Nexus days, Sean Parker set up this immune therapy collaboration with 7 or 8 major cancer centers. And this is looking at the addition of checkpoint to chemotherapy and looking at the addition of an agonistic CD40 molecule where that's also being combined with chemotherapy. So 1 immune agent versus 2 immune agents with a backbone of cytotoxic treatment. So this is underway and about to go to the phase 2 components. And then in the second line setting, a big ongoing study is a randomized phase 2 with a chemotherapy control and several experimental immune-based options. And you'll see looking at MEK combinations, looking at this PEG-PH20 molecule, and looking at CXCR4, other modulators of the microenvironment. So both of these studies, it'll probably be a year to 18 months before we have definitive data. So last topic, just a little bit about mismatch repair deficiency, and I in particular want to highlight it because it was one of your group here, Ian, who did the substantive part of the who did the substantive part of the work in this, and we're kind of very proud of this in terms of what it means in pancreas cancer. So just a reminder that mismatch repair deficiency can be driven by germline mutations in MLH1, MSH2, these are the Lynch genes, etc. But it can also be driven by somatic events, and that's typified in colorectal cancer by hypermethylation of MLH1 in particular, and in endometrial cancer by a significant number of somatic events. But in pancreas cancer, it appears to be a little different. And given the luxury of tissue, it's difficult to do immunohistochemical testing on every patient because we'll use up the tissue for one immune marker. So we essentially have moved to using next generation sequencing because of the ability to identify somatic treatment application for clinical trials for standard of care and the germline part. But using a bioinformatics analysis, you can identify this group of patients who have mismatch repair deficiency. And I think it gets around some of the vagaries of IHC testing, the limitations of tissue, and also the fact that microsatellite instability testing is derived from colorectal cancer from 5 genes, but we don't know that the same 5 genes are the key ones that are relevant in pancreas cancer. So it's sort of agnostic of the individual gene and looks across the whole genetic profile. So pembrolizumab was FDA approved in 2017 for any advanced solid tumor where mismatch repair deficiency or microsatellite instability was high. There was a small number of patients with pancreas cancer in that cohort, and one of the observations, like in the BRCA setting, was that there was a very high response rate and some of these quite durable, and that led to the FDA approval across those combined 5 trials. So in pancreas cancer, we looked at a cohort of 800 patients. We saw a small number of patients who actually had mismatch repair deficiency. They all had germline Lynch, so we didn't see any with somatic mutations that contributed to it, and that is in contradistinction to what the literature might suggest. These patients had a high level of MMR protein expression, that a high mutational tumor load, and by definition that they had a high elevated MSI sensor score. So looking at this graphically, you'll see that the typical individual pancreas cancer has a low mutational burden, and this is a very topical topic these days in terms of looking at tumor mutation burden and outcome with regard to immune therapies. Obviously not a surprise here and fits with what we've seen already, but the group of patients who had germline events, who had mismatch repair deficient pancreas cancer, had a very high mutational loads, and a number of these patients went on to receive checkpoint inhibitor therapy, of which a number developed a significant response. But I would say it's not all so simple. We had one striking individual who we've been looking after for a while now, and he was diagnosed with pancreas cancer, which metastasized shortly after, about a decade ago. And during the subsequent decade, he developed 4 other malignancies and has required intermittent treatment for his pancreas cancer, but ultimately it was one of his other malignancies that succumbed, and several of those malignancies occurred in the face of immune-based therapies. So it's still not a definitive answer to this group of patients, but certainly there's a biology that's different, and there's targeted treatment opportunities. And we put together, in collaboration with our genetics colleagues, an algorithm for how we should do this in pancreas cancer. And there's a lot of directions here on this, but it all kind of points to the efficiency of next generation sequencing because of the amount of information that you can glean from that beyond this specific small subset. So I'll leave you with these conclusions with regard to where we are with pancreas cancer. I hope you'll be convinced that now for a group of patients that there are some biomarkers that we can use and can apply on a routine basis. As we discussed, our goals in terms of the next year are to try to establish routine germline and somatic profiling. I think it's fair to say that we haven't at all realized the full potential of this in any way yet, and some of this is clearly discovery, but the hope is that that will, again, for an increased group of patients, help refine treatment approaches. I think the good news is that there's a lot happening, and areas of potential promise are this modulation of the microenvironment, clearly DNA targeting, and I think we now accept as a group in the field that that's a strategy of clear relevance and an important subgroup to identify. And this whole question of where immune therapy fits beyond the very small subset of patients with mismatch repair deficient disease. On that graph of mutation burden, you may have noticed there was a small number of patients who have a higher mutation burden beyond the average, and maybe there's something there that we're trying to tease out at the current time. So thank you. I'll stop there and certainly be happy to take any questions.
Terrific talk. I want to take you in a slightly different direction, because I think with this internal medicine audience and a lot of folks in primary care, as we get better at taking family histories, we have patients insert their family histories through the electronic medical record proactively, and we're asking more, and certainly I think as a GI, but even in primary care, we're hearing more patients who say, I have a family member who had pancreas cancer. And a lot of folks are saying, well, there's a genetic revolution, and this is great for patients who've already been identified with cancer, but they're asking us to go into risk stratification or certain screening programs for higher risk. Do you see a role for genetics in that realm, where patients are coming to us saying, I have a family member who died, I don't want to get pancreas cancer, I know it's often late when it appears, and it might be too late for me, let me try and hit it off at the pass. Can we use genetics in that realm? Do you see a future for those folks as well as for the folks already diagnosed?
Yeah, I think that's a very important question and topic for which there isn't black and white information in terms of guidelines. So bottom line, just with regard to screening, there are accepted consensus and expert opinion guidelines, but there's not, I think, widely endorsed guidelines in terms of what to do. For subsets of patients, so for healthy BRCA carriers, who have family members who've had pancreas cancer, that's a group where we do think about considering prospective screening. And as I think you were alluding to, there's no consensus on what test we should use, how often we should screen, what should be the limit in terms of the family that we should screen. But I think increasingly there is an acceptance that we really need to look at this, and there are many prospective national and international studies looking at this. I think we've been sobered by our own personal experience. We have a large registry in place now since 2002 that Robert Kurtz and the epidemiologic group have run, and identifying high-risk individuals who have either a germline mutation or have multiple family members with pancreas cancer who were diagnosed at a young age. We've had several people who, even under the observation and screening, have been identified with metastatic disease between screening intervals. So that's disappointing. I think we know for some individuals we certainly can identify at approximate time points, but it remains to be seen if this is going to help us. The other, maybe broader population of patients that people are thinking about this is people who develop diabetes without a personal lifestyle or family history of diabetes. And the Mayo Clinic have done a lot of work in this area. and suggested that that might be a subgroup of patients again enriched, because I think application for the wider population is clearly not tenable, but that might be another group to think about. But no question, there's a lot of work to be done, and I think this is going to become an increasing topic of relevance and focus. No?
Good morning. I have a question from downtown. And it was an excellent talk, very enlightening. Thank you very much for that. So my question is also based on screening. So a lot of lesions are being predisposed to pancreatic cancer, like chronic pancreatitis. And is there any difference in response to chemotherapy for patients who develop pancreatic cancer after having a long history of chronic pancreatitis? And is there any, the second question is also related, is there any research that would look into the role of genetic testing in predisposing lesions like IPMNs or mucinous adenomas?
Yeah, so to also very good question. So the first one related to people who develop pancreas cancer on a background of chronic pancreatitis, and it's not, I would say, a huge population. The relative risk increase is about 1.1, 1.2, but it's a consistently observed finding in the literature. But we have a large referral center, and we see 600 or 700 patients each year with this disease, and it's a small number of people that I can think about clearly have had chronic pancreatitis as their background. So the bottom line is, I think we just don't know whether there's a difference in outcome. I suspect they may not do quite as well, because I think there may be some lifestyle considerations that have contributed to the risk that might have an impact on treatment tolerance and etc. But that's kind of speculation. There are very rare groups of patients that we'll see with germline mutations in SPINK or in not in autoimmune, but in familial pancreatitis and cystic fibrosis, where they have other issues that contribute to difficulties with treatment administration. So it's not a big N, again, that's been reported here, but at least from what I've witnessed, the outcomes are probably less good, I suspect. So your second question was, what do we know about genetics and predisposition risk for patients with cystic lesions of the pancreas and IPMNs? So there's a lot of work being done on that, and Peter Allern, who some of you may know, is a surgical oncologist at Memorial, has really developed this area. And there's a first randomized trial that's been funded by the NCI that's about to open in this space for patients deemed to have high-risk IPMNs who've undergone resection, where they're allocated to a combination of a celecoxib, so COX-2 inhibitor, and metformin combination, looking to see, because of the importance of those pathways in terms of development, whether there might be a reduction in the risk of developing pancreas cancer. That's again clearly a high-risk group. There's a lot of work at proteomics and cyst fluid analysis and genetic markers in the cyst fluid that might again enrich for the group of patients that have a higher risk of going on to develop an invasive pancreas cancer. But I think we still have a lot of work to do. Many of you may be aware that GNAS, when we see a GNAS mutation along with a KRAS mutation, probably it's suggesting that particular pancreas cancer occurred on the background of an IPMN. So that may be an enrichment strategy as well, but none of these are absolutes.
Another question from downtown. You mentioned on the slide, but I don't recall hearing you talk about vaccines. And I heard anecdotally that Rubenstein, who won the Nobel Prize for his work on dendritic cells, created a vaccine for himself after he was diagnosed with pancreatic cancer and survived for 5 years.
Yes, so I had again the honor of looking after Ralph Steinman, so I know the story well, and he and his family, have allowed us to be very public about this. It was fascinating. It's hard, in all honesty, to know how much of it was the immune-based strategy. He was probably one of the first patients with pancreas cancer to get an anti-CTLA-4 therapy. But I do think that he had robust and reproducible response to cytotoxic therapy. But I think there was something to the fact that he received multiple vaccines. He received about 4 over the course of his disease, had primed his cancer to benefit more from the cytotoxic therapy. So his disease would respond and then would progress. He'd be off therapy for a bit, and that happened multiple times, which is very unusual. So there's a lot being sort of developed from that. One of the vaccines that he was on was the GVAX vaccine that's been studied for almost 20 years now by Liz Jaffe and her group at Hopkins, which is an allogeneic vaccine that comes from 2 individuals with pancreas cancer where their cells were irradiated. The idea being that it's an enriched source of antigens, not defining what those antigens are, but lots of targets for the immune system. Having said that, I think this has struggled in that while there's a lot of data looking at it, it's still not an approved strategy, and I think pretty clear on its own will never be. There's a lot of approaches now using virus vectors, using checkpoints in combination with vaccines. The key goal and the goal of all the immune strategies is try to see if you can make the immune environment more responsive and make those T cells activated and be where they should be. And this may be one of the ways of doing it. Yeah, but there was for those that are interested, a New Yorker article on Ralph Steinman's story, and he died shortly before the announcement. It was actually days before the announcement of his Nobel Prize.
This was a very exciting talk, and thank you. You mentioned the biomarker, and the prospects of a biomarker are really exciting. Could you say a bit more about its applicability at the present time?
Yes, so biomarkers, and there are many of them, so you can talk about disease are individual related. I think the practical ones that we now know have validated data supporting them are patients with germline BRCA mutations for platinum and PARP inhibitors. PARP inhibitors are still experimental, but they're going to become a reality soon. Subset of patients who have mismatch repair deficiency, it's a small group, but that's a biomarker selected group. We talked about data looking at hyaluronan in the microenvironment to enrich for a group of patients that might benefit from PEG-PH20 on the backbone of standard gemcitabine nab-paclitaxel. That remains to be proven, and that's being tested in a phase 3. But they would be several of the biomarkers that I think are pretty universally accepted now in the field with regard to targeted based approaches. Okay, great. Well, thank you very much.
Everybody.